So what we're looking at here is the portal view of Engage Consult. So essentially, we've already clicked on a homepage banner for us a practice website, and we've come through to this view. So Engage Consult Get Help Online is the link through to the consultation service. Self-help advice from NHS UK comes as standard. You can also upload weight measurements and blood pressure measurements and attach those to the patient record in the same way that you can an Engage Consult account. And that comes as standard as well. But you'll see here that we've also added the NHS 111 online symptom checker. And indeed, a practice can add any number of additional services that they want to. So currently, quite a few practices will have links through to either their system online or their patient access, appointment books, and repeat prescriptions and medical records access, or to local relevant service like local sexual health services, things like that. So this is a configurable portal, so the practice can configure this themselves. So, but let's just focus on the core offering, which is doing an online consultation. So I'm going to click Get Help Online, and I'm prompted to ask if I want to sign into my account or continue as a guest user. So you can create an account, and that allows you to not only log in quicker, but it allows you also to have access to secure online two-way communications, which are not available to a guest user. So if you continue as a guest user, then you have to be communicated. You have to receive communications back from the practice, usually by telephone. Okay, so we'll continue as a guest user. All right, I'm going to put in somebody's details who I know is in my Emis Web database. So we're now adding in the problem, sore throat, and what I'm going to do, I'm just going to answer this query in a way that is consistent with this being a viral sore throat. The underlying question asking engine in Engage Consult is called Instant Medical History. It's got a provenance now of nearly 25 years since it was originally developed. And the underlying database has over 76,000 questions in it currently. It's being developed all the time, and they're all linked by branching logic. So what that means is, provided that my answers are consistent with being viral sore throat, that's really the only thing that will be explored in the questions. However, should my answers suggest something more serious is going on, then indeed those other potentialities will be explored, rather than simple viral sore throat. So there's no such thing as a one sore throat questionnaire. It will depend entirely on the answers given. You also notice that I can add in additional concerns. And in fact, there's no theoretical limit to the number of issues I can explore in any one episode. But the reality is the vast majority of people, 85 to 86%, I think it is, only ever look at one problem. About 13% put in two, and then the remainder are three or more. And what happens is each problem is explored sequentially. So it doesn't try and mash it all together and say, well, you've asked about sore throat, you've asked about something else, you've asked about a third problem. Let's put all that together and explore one condition. It will explore them all sequentially. We won't put any additional problems in at the moment. We'll just do sore throat. And immediately we're offered information text. Now, this is an example. This is configurable by you as a practice. You can decide what you want to say here. So I was talking with some practices yesterday who want to offer very specific advice about please go and see your pharmacist, for instance, if you've had your sore throat for less than 2 days and you don't have a temperature. So you can configure the information text you want to provide here. There's a choices link here to sore throat information. That will come as standard. You can add additional links yourself. So for blue surgery, we've added an additional link to a nice little video by John Griffiths talking about how he managed his own sore throat. So this is a way in which you can signpost your patients to alternative courses of action, as is consistent with your current policies. So we'll continue here. We won't look at the information now. We'll just continue. And then we have ideas, concerns, and expectations questions. Again, you can write these yourselves, or you can use our basic boilerplates. You can add a file or a photograph to all requests. We're not going to do that. Just a little speed bump here, just checking that this is the right course of action for you. Obviously, we've already pointed out that we're outside the same day response window, so you may decide actually at this point, I very definitely want to call the surgery this afternoon rather than say wait until Monday morning. But the vast majority of people actually do start the questions at this point. So I'm going to say answer most of these in the negative. So I haven't got a cold or flu to begin with. Okay. So no to all of those. Yes, I do have a sore throat. Now you'll notice that I can go back and change answers. I can skip questions. I can finish at any point. Don't know also is a valid answer. I'm going to say I don't know to that. I wouldn't be quite sure if my throat was red or not. I'd probably notice that. You can go off and check. There's quite a long time out. I think it's 10 minutes, so there's plenty of time to go off and have a look. I'm going to say no to that. No to that. I'm going to say no to most of these now. Yes, I can actually soothe it. It's not so bad. My glands are a little bit swollen. No, I don't have a gravelly voice. My voice hasn't changed. I don't have a cough. I haven't had my tonsils removed. My glands are a little bit swollen, let's say. And I don't have an earache. So sensible again, it's relevant, an ENT screen. So unlike 111, which will ask me a lot of other rather irrelevant questions about blood loss and in and out of consciousness and so forth, I'm only going to be asked relevant questions to the condition. So again, it makes sense to check whether or not I'm a hay fever sufferer, and indeed whether or not I've got a history of sinus infection, both of which can cause sore throat, obviously. No problems with my breathing, important check there. I'm not achy. I'm not about to come down with something, ditto headache. I don't smoke, again, sensible question. I'm not after a fit note. Question: if they select, sorry, I've got my control panel minimized, so I do lose sight of the questions. The question was, let me get down to that. Let me just try and respond to that question while we're doing this. If they select finish now, does that exit? No. You just finish now and you continue. You're not forced to complete a questionnaire. You can finish at any point and you just continue on in the process. You're not bounced back to the home page at that point if you decide to finish now. I'm going to say no to that. And again, now we've reached the end of this particular questionnaire, I'm being prompted again to have a look at the self-help information. So let's say I'm one of those patients who is prepared to do this. So I'm going to go and look up the choices information. I understand. Okay, so this is coming directly out of the choices library. Okay, and let's assume that I found that quite useful. So in fact, the system asked me whether or not I found it useful. I'm going to say yes. So there's an obvious follow-up question to that, which is, of course, do you then still feel the need to contact the surgery? If I said no at this point, the system checks with me. Are you sure? If you select yes, your request will not be submitted to the practice. So I have to be really clear that this is an episode of self-care. So I do want this to go to the practice. So in fact, I'm going to say no at this point. So we'll continue. And here we are. Here's the report. We'll look at this when we get to the practice. But just to say, I can add in additional information and I can correct errors there. I can actually download it if I wanted to. I can accept and send. So that's now gone. It asks me whether I want to register. So there are a few questions next time and I can use secure two-way. I can say no at this point. I am going to show you the survey though, because nearly 20% of all users do this on a regular basis. So it asks me, have I used this service before? I can say yes. Do I think this is a better way of contacting the practice than previously? I'm going to say better, of course. Would I recommend it? I would recommend it. I could put some free text comments in there, but I won't do that for now. I'm just going to continue. So that's that. So this has now gone to the practice. It doesn't go to your email. It goes to a simple browser-based tool called Encompass LT. And here it is. You fire this up at the beginning of the day. It sits alongside your Emis Web. You don't have to keep changing passwords. It doesn't go to sleep. You don't have to log in again. It remains available all day once you've logged in at the beginning of the day. I am currently looking at incoming patient requests. and you can see there's Jack Smith's request is in there. Just to explain the sidebar a little bit, all means all the messages I can see and action. My messages just means those messages have been sent to me personally. Messages in admin, messages for Dr. Griffith, duty doctors, practice nurses, and so on. The system has the capability to what we call cover both colleagues and groups. And what covering means is that I can see and action those messages. So currently amongst my colleagues, I'm covering for Dr. Griffiths. If I stop covering him and I go back to the message view, you can see that Dr. Griffith has messages have now disappeared from my message sidebar. And it's exactly the same with groups. So you don't belong to groups per se. What you do is you click and cover a group, and it's like having just a key to a mailbox. Okay, so everything though defaults to the incoming patient request or incoming messages box, and you can see it says there medical request for anyone, but there are some different variants here. So let's have a look down here. Medical request here for duty doctor. Medical request for anyone. Most of them are anyone, but this is where your as a user your preference is expressed, because that could, for instance, have said medical request for Dr. Griffiths or and so on, or medical request for practice nurses. But everything still comes into this one incoming box. So we'll view this. Okay, we're not matched in the clinical system yet, but we're actually linking to my version, my Emis Web, and it's asking me, is this the correct patient? So I'm going to say, yes, this looks like the right patient. So we change the status to patient matched in clinical system. And of course, now what we need to do is verify their identity. Well, we don't do that automatically, and we're not, we don't tell you how to do it. What we do is we provide you with the opportunity to indicate how you've actually identified the patient and to have that information logged in the system. So we're live now in over 100 practices, and we'll be, by the end of August, we should be live in nearly 160 practices. We've launched a huge number of practices into test mode in recent months, in recent weeks rather. The vast majority of our live practices simply check information, choose the option about checking information held against that held in the clinical record, confirm identity. Now, the thing is, if I'm going to get back to this patient and just discuss ways in which they can manage their viral sore throat, that's probably sufficient. I probably don't need to be any more concerned about their identity. But if, of course, on the other hand, I was going to ring this patient back and discuss anything confidential, then clearly I'd probably still want to check that they were who they claimed to be at the point of making the phone call, just as you probably do now when you do telephone consulting. In many ways, this is very analogous to telephone consulting. Instead of the information coming in over the phone, it's coming in via the digital channel, but you're responding on the phone. So all your IG requirements remain the same. So if we just have a quick look at the report, you can see here that the patient has chosen to accept the out of hours override. So they've accepted the fact that they won't be hearing from you until the next usual working day, which will be Monday, of course, today. So there we are. There's the PID. We didn't answer any of the ideas, concerns, and expectations questions. There's the links visited. So it shows that we visited the choices link and that we found it useful. So it's an opportunity for some patient education, probably, because it's quite likely you're not going to be saying very much more than was available in the choices information anyway. So it might be an opportunity at that point to encourage self-care. And you can see everything that I've reported in the positive. So actually things that are pertinent to my condition are in the emboldened text, but all those other questions that were asked that I said, no, that's not a problem for me. They're all there, but they're grayed out. So typically clinicians interrogate the positives very quickly, and then they go back and explore what other questions were asked as well. But you'll notice here, because we answered all the questions in this case, we've tripped over one of the standard instruments and self-assessment scales built into the system. There's around about 190 currently, and all those that you're used to using in general practice are built in here. So, PHQ-9, GAD-7s, knee pain scores, and so on and so forth. They're all built into the system. Providing all the questions have been answered, you will get this decision support, but only if all the questions have been answered. So in this case, we did answer all the questions, so this is giving me a percentage risk of this condition being bacterial pharyngitis, and it's very low, obviously, because the way I answer the questions would be inconsistent with it likely to being bacterial pharyngitis. So we can imagine that we're going to just simply, if there are signposting capability at reception, I can probably just directly assign this to, let's say, practice nurses rather than the GP. Okay, this has now gone to the practice nurses inbox. There it is, so we can view it just as before. We can see already that their identity has been verified. We can go through the report. Now I can only get back to them by phone, so let's assume I've called the patient and had a conversation, and I've given standard advice for sore throat. Let's say advised, call again 3 days if still unwell, or whatever your procedures would suggest. You can borrow that information, and now I'm actually going to send all of this to the clinical record. So we can see it's pre-filled as engage consult medical request, problem reported sore throat. I've just borrowed that detail, and I'm now going to send all of that to the clinical record. It tends to be a bit slow for me because I'm working over a virtual private network to our offices in Norfolk, so apologies for that in advance. It will happen. Okay, so we've attached that information into the patient record, so you can go and open that directly. I don't have to toggle between the two systems and go and look for that patient. I just click on the link to open the patient record. Okay, and if I go to consultations, here we are. So there we are, engage consult medical request, problem reported sore throat. There's a note, and you'll notice also that there is a code associated with this, so you can, when you report in Emis, report on all those engage consult initiated episodes, and of course you can open this directly as well from the patient record journal. Where we're going with this is hopefully by the end of the year we will have coded entries associated with the report. We're working on that now, and of course that will be SNOMED. Okay, but you can open it directly there as a PDF. Okay, so this is a workflow and integration tool. So not only is Encompass LT used for with matching and vouching the patient identity and placing the information into the record, we also want to use it as a workflow. So what we need to do, having reached the natural conclusion of an episode, is to complete it. So I'm going to click complete. It explains exactly what this means. So we're going to take it out of the normal list view. So with complete message. Of course, the information is retained in the system, so it's now left the workflow. If I have to maybe reopen this later, I can do so. I tick show completed. Just give it a moment, and there it is today, 13/26. So we can view this. And if I needed to, let's say the patient's called in a bit later saying, actually, they're feeling very much worse today. They've actually been sick and they're feeling quite faint, for example. I could actually reopen this episode, add that information in, and also my suggested next steps with that patient. I won't do that. I'll keep it as completed at the moment, because otherwise this message view continually gets clogged as we do more and more demos all the time. So that's an example of a journey with the patient as somebody who has yet to set up an account. And now what I'd quickly like to do is do something similar with the patient as an account holder. So let's say it's 3 days later, and I'm actually feeling a lot worse. My sore throat has not improved. I've now got patches all over my tonsils and so on and so forth. So I'm going to go back. I'm going to make contact with the surgery again. I'm going to continue as oh no, I'm not going to continue as a guest user. My apologies. I'm going to log into my account. So I'm going to log into this account here. I've already got Jack Smith loaded into my browser, so I'm going to log in. Okay. Okay, and you can see, hang on, okay, sorry, I just need to stop some notifications to stop this happening. So I need to snooze this. There we go. The conversation's going on all the time. So let me just dismiss that for now. So I'm going to do a request for Jack Smith. I always have to confirm that I remain registered at the practice. I'm not using it for a medical emergency, and I remain responsible for escalation. That's essential. Every episode I have to do that. You'll notice my number's already in there. You'll also notice that I didn't have to do a GDPR statement. Okay. Again, obviously, with outside the same day response hours, I'm going to choose medical problem again. Okay. I accept that. Yes. Anyone? Okay. Yes, that's fine. New problem. Now, before I go on to report on my worsening sore throat, what I'd quickly like to do, just to sort of speed up the demonstration, is show how we manage alerts for potentially dangerous conditions. So if I put in here chest pain, and we'll come back and continue with the sore throat narrative shortly. I'll continue. We get a flag, and we have a number of basic flags built into the system, but you can actually augment these flags, and you can add additional flags if you like. So what we're saying here is that we're not going to stop the patient contacting you just because they've put in sore throat, but we're drawing to their attention that this may not be the best course of action. And certainly if they had any of those indicated symptoms, they should call 99 straight away. So obviously, most chest pain is not related to a cardiac episode in any way. What is it? The sort of 80 to 85% is something else completely. So it doesn't make sense to actually stop the patient contacting you just because they've said chest pain. But what we need to do is make sure that they understand that it could be potentially serious, and if any of the following pertains, then they should obviously choose a much more urgent course of action. So the patient has to click I understand if they wish to continue. Okay. So that's how we handle it, and I'll show you how flags are instanced in the surgery view. But actually, I want to continue with the sore throat narrative for the purposes of this demonstration. So I'm going to put sore throat in again. Seen all this before, so I won't talk about this. Did I do new problem? I did new problem, didn't I? Yes, I did. I meant to do patient. Doctors asked me to get back in touch. Okay, well, let's assume I've done. Doctors asked me to get back in touch because I would have had a different question there. But let's just start with this. Feeling much worse. Can I see someone? Something like, okay, off that goes. I'm not going to add any other questions. Okay, I'm going to do that. And indeed, I'm not even going to answer the questions. I'm just going to send the request as it is. Okay. Now, as I'm an account holder, we default to secure online two-way as the way of communicating with the practice, but we offer an opt-out. It may not be possible for you to make use of secure online two-way today, so we have to offer that opt-out, but we'll ignore that. We do want to use it, so we'll send that into the practice, and that's gone. You've seen all that before, so we won't look at that again. So here we are, we're in incoming patient requests, and we can see here that Jack Smith is an account holder because secure two-way messaging is enabled. Just to say though, going back to the chest pain issue, let's have a look at how flags are shown in the message view. And you can see there these are examples of flags being shown. So you can see straight away in the message view if a flag has been displayed to a patient, and that gives you the opportunity to prioritize them. Okay, and if I just quickly show you how it looks in the view, we actually display the flag shown to the patient. There we are. Come back to incoming patient requests. Let's have a look at this then from Jack. So here we are. So we can see his identity is actually matched and verified as an account holder. So previous to this, he would have gone through a verification process. I think it's probably worth a moment to dwell on this, because obviously there's the potential for somebody to have created an account and not yet have been verified. So it'd be interesting to explore how account holder verification is undertaken. So let me just remove the link for now. Okay, so we're going to go through the matching process again. So we're going to match, and we're going to say, yes, this looks like the right patient. So we've got patient matched in clinical system. Okay, but of course they're not yet verified. So let's just click verify patient. Okay, so before we've got a slightly stronger message here than before. This user is an unverified Engage Consult account holder. Before you vouch for their identity, please take steps to ensure that this is who they claim to be, as any subsequent contact will appear as vouched. If you're at all unsure, just select cancel. So I'm actually going to do that. I've got two options really at this point. I could probably ring them back. I could look at their record, pull out some information that only they would know, give them a call and ask them some security questions before we verify their identity. However, because we have a two-way channel with this patient, I can in fact do that now. So I could actually send 3 security questions based on their clinical record. You know, when did you last come to the practice? Are you on prescription meds? Have you had a hospital appointment in the last 2 years? That sort of thing. And I can actually do that because, in fact, I'm not sharing any sensitive data. I'm actually asking questions, but it does warn me to make sure that I'm not sending anything that of a sensitive nature. So I understand. So I've actually asked my 3 security questions via the secure channel. So what happens is that goes to an alert goes to the patient's email. I'm just bringing that, excuse me, I just have to keep moving the control panel around. So I've got a new message. So let's go and have a look at this. Oh, it's not come in yet. That's from a couple of days ago, from a demo a couple of days ago. There's usually a lag about of a minute, but what happens is you can see exactly what happens. Dear Jack Smith, you have a new message. Please sign in at the link. Okay, so we'll click on the link, and of course I'm already logged in, so in fact we'll go straight through to the my portal, my own personal portal, because I was already logged in. So let's go and have a look at my message. Go to my messages. Here we are. Okay. 3 security questions. Okay, that's fair enough. They're looking after me, and you can see that I'm sort of. Let me just dismiss that. That's from a couple of days ago. You can see I'm sort of slightly co-opted into the workflow at the moment. However, the important thing is that I, as a patient, can only respond. I can't initiate conversation thread. So I'm going to give my answers. Send that away. Off we go. Okay. It tells me I'm waiting for a reply from the surgery. So let's go back to the surgery workflow view. Okay, so my 3 answers have come in. That's great. And they're correct. Good. So let's just verify the patient's identity now. And I can choose that I've checked the information provided against that held in Emis. Okay. So now I can respond to their request. So let's have a look at this. So, okay, I'm feeling much worse. Can I see someone, please? Okay, well, it's a bit concerning. They've had the sore throat now since Friday. It's now Monday. They're feeling much worse. So chat with the doctor. Let's bring them in. Let's say later on this afternoon at 5:30. So I'm going to type a note. Can you come in to see Dr. Sills at 5:30 p.m. Okay, send that to the patient. Always checks that I'm doing what I think I'm doing. I might be typing a message to my colleague and I've inadvertently hit the send to patient button. So we're always checking all the time. So we'll send message. Okay, that's gone. It's unread at the moment. So again, they're the patients in our workflow at the practice. Okay, so okay, that's good. I can now see it. So it tells me it's been read. Okay, I can respond, yes, thank you. Okay, and back to the practice. That's good. Let's acknowledge that. Let's just say see you then. And let's bring this to a conclusion. Don't want this to go on forever. So now, having done that, I can take this out of the workflow. So I'm going to complete. And I've got an alert up that says this request has not yet been attached to the patient's clinical record. And again, I did that deliberately to show the sort of fail-safes built into the system. So it's making it clear that this is something I really should be doing. It is giving me the option to continue without attaching, but obviously for the sake of everybody's safety, it's much preferable for me to actually send this to the clinical record. So I'm going to go send to clinical. And just to show, it isn't just the original request that gets attached, it's all the comms with the patient as well. Okay, I can put some detail there. Appointment 5:30 p.m. Dr. Sills. Okay, then PDF to clinical. Apologies for the delay. Quite a long one. There we go. I won't. You've already seen how it looks in Emis, so I won't go and do that again. So now, though, I want to take it out of workflow, so I'm going to complete. Okay. No, I've got another notification. And again, I did this deliberately. Please acknowledge all messages before completing. So in other words, I cannot take anything out of the message view, the workflow view, without having acknowledged that I've read all messages. Obviously, in this case, it's trivial, but obviously there is a possibility of missing an important message. But you can't actually take things out of the workflow view unless you've acknowledged that you've read all messages. And now I can complete. Okay. Just to show you a couple of other things that I think are important. I talked about information text and flags. If I go to the content here, let me give you an example. So this is where you would actually configure your own information text, or we can do it for you. And here we are, toothache. So here's a good one. So we've got here, toothache is best dealt with by a dentist. Please contact your local dentist. A list can be found here, and actually we put it in the information text, but actually we should have just put this list here. In fact, I'm going to edit that and just show you how easy it is to do this. I'm going to edit the information text. I'm going to actually pick that list up there, get rid of it. Oh, hang on, edit. Okay, there we are. That shouldn't actually be in there. Okay, I'm going to go to the resources. I'm going to add a link. Resources, add a resource. So, oh yes, that's right. So go GLOU Gloucester dentists. Like that. There we are. So now, if somebody put in toothache, they'd be presented with this information text. Toothache is best dealt with by dentists. Please contact your local dentists. Okay, and there'll be the link, active link to the dentist there, and it's as simple as that. And this is where you can see all the flags as well, the alerts to more worrying conditions. So if I put in something like, I just put in pain here, for instance. There's a flag for back pain, and you can have different flags for in hours and out of hours as well. Calf pain, and so on. And you can edit these, and you can add additional flags yourselves. The other thing to say is from the control panel, you can also access reports on usage. So you can just choose something like a usage report. Yes, why not? Dates between. We've done a lot recently, so I'm not going to go all the way back to May. I think I'll just go to 1st of June, create a report. There we are. And that shows you the usage in that period, 1st of June to today. Let's go. Let's give an example of a complaints report, which is conditions report. Actually, complaints is a terrible word. Again, 1st of June to 21st of June. If I do that again, unsurprisingly, because this is our demo website, we've got a vast number of sore throats, chest pains, knee pains, and so on. Okay. And also from here, you can actually generate quite detailed full transactions reports as well. And you can download those as CSVs and play around with those. Okay. And I think with that, I've reached the end of the functionality. So really, I guess now over to you for questions.
I think, Chris, you've got a question in the chat line.
If they finish now, does that exit? No, as I said earlier, you just continue with the process. You're not forced to. Completing is not compliance with everything is not a prerequisite for using the system. You can finish at any point. So it says also further, or does it take you to the next stage? Yes, sorry, okay, we've done that one. Is there a further question there? Julie, brilliant, thank you. Oh, that's nice. Can only the clinician who responded click complete? Yeah, whoever has got it has got it, but that's only if it's open. So if you're viewing, if you personally, it doesn't just mean a clinician, but also administrator, whoever is viewing an episode sort of owns that episode. And actually, if somebody else wants to take it over, they can do, but they actually have to override the lock. But if you've dealt with it and you're no longer viewing it, anybody else can complete it, yes. It's only when it's being actively viewed is it sort of owned by somebody. Once you're no longer actively viewing it, anybody who can see and action that message can complete it.
Okay, thank you.
Any other questions? It's ominous silence. I know it's quite long. I mean, we've been going for 45 minutes. I guess you've probably all just about had enough. Oh,
I think I was. Sorry, I was just going to add, Chris, that
yes.
generally speaking, if a patient is completing the questionnaire online, it does only take about 4 minutes, 5 minutes tops.
Doing a request, you mean?
Completing a request, yeah.
Yeah. I think it's the average is actually between 5 and 10. Got a very good question here, and well spotted. On the graph showing sore throat, it had 2 bars due to a spelling error. How can this be stopped from happening? It's a really good point, and we have a task in at the moment to fix that.
With your, it comes into kind of an inbox, as it were, that anyone can access.
Yes.
And then you've got defaults like duty doctor, or do practices set up individual doctors or staff members' inboxes so that they can be allocated to an individual to deal with?
Absolutely, they do. I'd say the majority probably don't, but a significant minority of practices are happy to expose individual clinicians. to their patients, and yes, have individual message boxes for patients. But I'd say the majority of practices use the sort of duty doctor or just doctor process.
I was thinking more at the practice end rather than
Oh
the
yeah.
patient.
Well, everybody would in fact have an inbox. If you're a registered user,
Right.
you do have you that comes with your own inbox, so to speak.
Okay.
Yeah.
That's what I thought from what you'd shown, but
Yes, it's just that simply I'm not covering for many of my colleagues.
yeah.
Yeah.
Okay. So an administrator could send a request to the most appropriate individual, not just to a group of people.
Correct. Absolutely. You know, if I just do, you know, cover a couple of other people. That's just, there we are. If I go back to messages, there we are. So that means I as an administrator can, in fact, I don't even have to cover them to actually send them. It's just that I'm just showing you that those message boxes exist, so to speak.
Yeah, it's similar to the workflow manager in Emis.
Exactly. Yes. Yeah. In fact, Encompass itself was a very early workflow tool before most of the clinical systems had workflow themselves, and it was actually quite widely used. But as obviously PCSs have developed their own workflow, it's somewhat lapsed. But it was a really popular tool. I mean, we're talking about 15 years ago now, quite a long time ago. So we like to think they're modelled on us rather than the other way round, is my point.
It has been sort of set up, hasn't it, Chris, to be as flexible as possible, so that, you know, not to if you're in from a practice point of view, you should be able to have the system work around your
Yes,
model and practice that
that's right.
exists,
Yeah.
rather than you having to change your practices to fit around the system.
Yeah, exactly. So, you know, particularly around things such as the length of the same day response window. When do you want that to start? When you want that to finish? That's entirely in your control. You know, what clinicians and what administrators do you want using the service? Entirely in your control. How do you want those users exposed to your patients? Again, that's all entirely in your control. Setting up the portal view, again, entirely in your control. So our whole idea is that we are trying to support what you currently do, rather than have a kind of standardized service that you somehow have to shoehorn in to how you currently manage your access.
Can you hear me?
No, were you asking a question? No, nothing at all. I can hear you now when you said, "Can you hear me?" But I didn't hear you
I
before.
just said that first before I plunged into my question. On the consultation note on the system,
Yes.
how do you access the information that the patient's put in? Because you've really only got a little summary, haven't you? So can you access all that information that the patient
Sure.
entered?
No, absolutely. It's there as an attachment.
Right. And does it identify which clinician? I didn't see that. Which clinicians completed the task, or so you know who to blame? Yeah.
Let me. Yeah, I know what you're saying. Yeah. So I've just opened up the information. So probably went through this too quickly before. So there we are. Status changed, linked and verified. You can see who is actioning it. You see. So it's me as as Richard Sills. I'm logged in as my colleague Richard Sills at the moment. So you can see that it's actually Richard that's been doing all of this.
Okay, thanks.
Yeah. Sorry, Hilary. The trouble is I have to go to open up the full control panel because they only show very short, briefly. Does the software prompt the surgery to review their resources? No, it doesn't. But what we are currently doing, and certainly we should have this by the autumn, by September, October at the very latest, is we have agreement with the DOS team to make use of their services in this environment. So we will be, rather than necessarily, at the moment, you're right, it's a bit hydraulic. It's good that you can do it, but yes, it means either we or you have to do it, and therefore how are those links maintained? It's a really good point, but we will have access to DOS services shortly, so that hopefully overcomes the sort of maintenance issue. Any other questions? Okay. Is everybody okay?
Yep. Thank you.
Okay. Well, in which case, if it's okay with everybody, I'll bring this to a conclusion.
Thank you very much. Thank you.
Okay. And who was it that wanted a recording of this?
We'd like one. Yes, please. North Curry.
Okay, Julie. All right. What I'll do, I will send. Please look out for this. I will send a link via WeTransfer, and you will be able to access an MP4 file of this. I'd like to get it up on our YouTube channel, but I know that takes a while because I have to put that in as a request, and it could be a few days. But I could actually, if you don't mind, just sort of downloading an MP4 when you get the request from WeTransfer. You can have a version of it yourselves this afternoon.
Thank you.
Okay. Thanks, everybody.
Okay, thanks, Chris.
Cheers,
Thank you.
Bye bye.